Hello, everyone. Welcome to the Psychedelic Associations of Canada's latest webinar called Beyond Fear: How Psychedelics Are Transforming End-of-Life Care. We have 90 minutes together, and it's my pleasure. My name is Kimberly Iwamoto, and I'm going to act as your host this evening. I'm a past board member of the Psychedelic Association of Canada. I'm an active member of the End-of-Life Doula Association of Canada and am a Home Hospice Association ambassador. I am a death doula, and I primarily serve clients in the GTA and Southern Ontario region. Before we introduce our panel, I would like to take a quick moment to acknowledge this land and respectfully request that you also take a moment to think about your land and our elders and leaders in our Indigenous communities. For thousands of years, this has been the traditional land of the Huron-Wendat, Anishinaabe, Seneca, and Mississaugas of the Credit peoples. Today, this place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and reside on this land. So, at this moment, I am delighted to introduce our panelists. In no particular order, we will begin with Shannon Dames. Shannon is a third-generation Canadian. She's a mother and registered nurse with over 20 years of clinical experience, holds a doctorate in education with a focus on resilience development and a master's in public health. She's a professor of nursing and chair of the psychedelic-assisted therapy at Vancouver Island University and serves as the lead for clinical operations and curriculum development for Roots to Thrive Society for psychedelic therapy. Welcome, Shannon.
Thank you.
Nicola? Oh, I'm sorry?
Glad to be here. Thank you.
Oh, terrific. Wonderful. So Olga Nikolaev, close. Olga is a wonderful woman. I've known her through some other board associations. She is an end-of-life nurse educator. Olga is a fellow in thanatology with over 30 years of professional experience as a registered nurse, including hospice palliative care. Olga is the founder of Dying Matters and supports clients in Eastern Ontario, and is the founder and director of the Death Doula Ontario Network. Her current interests are in the field of psychedelics, spirituality, and end-of-life care. Olga educates both at the Centennial College and Douglas College. She has a diploma in nursing with her certificate in multidisciplinary palliative care. I'm going to wiggle through that. A master's degree in religion and culture focusing on death rights. She holds a certificate in cannabis science and has trained in PAT, which is psychedelic-assisted therapy sitter. And she's currently enrolled in a PhD program at the University of Ottawa in religious studies. So welcome, Olga. Thank you. Thank you for being here. Janice Hughes, next on my list. You're next on the hot seat. Janice joins us today as she is a person who has lived experience in the use of psychedelics when facing some very serious health challenges. Diagnosed with stage 4 breast cancer in the fall of 2021, Janice decided that she wanted to address this issue personally, and she applied through Health Canada with her doctor for access to psilocybin under Section 56 and was rejected. So Janice has a great story. We're going to hear from her shortly. Welcome, Janice. Thank you very much for joining us today.
Very honored to be here.
Thank you. Dr. Houman Farzi is a physician and researcher specializing in psychedelic medicine and palliative care, as he is an attending physician at the Division of Palliative Care at the Jewish General Hospital in Montreal, and clinical assistant professor at McGill University, where he teaches palliative care, mindfulness medical practice to and meditative practice to students. Dr. Farze is the founder of Mystic Health, which is a holistic health practice currently operating in Los Angeles, a trainer and a clinical trial site physician for MDMA-assisted psychotherapy for PTSD, which was actually sponsored by MAPS. So welcome, Dr. Farzin. Thank you. So, wow, we're getting going here. First of all, I really appreciate, before we get started, all of your expertise and your willingness to share openly and candidly. And I'm hoping we can have a beautiful conversation about this issue this evening. What I think would be appropriate, if that's okay with everyone, is I would like to put Janice on the hot seat, because she is the person who's had this lived experience. And I think it's very compelling because she's been there. You know, we come in from a clinical perspective or a sitter or a death doula perspective, but Janice is the one who's had to cope with this personally and first and foremost. And Janice, would you please maybe just give us a little bit about your story, who you are, and how you came to be involved in this space?
Sure. When my journey started, I was a 66-year-old semi-retired translator. I had never ever done hard drugs. I had smoked weed and hash when I was in my teens and 20s, but I had always avoided hard drugs, what I perceived of as hard drugs, for fear of losing control. Losing control was driving, not fear of losing control was a driving force in my life. But everything changed when I learned about the potential of psilocybin to jolt me out of my headspace. I was quite desperate. I had a bout of my lumpectomy. I contracted breast cancer, was diagnosed in 2011, had a lumpectomy, had a mastectomy, left mastectomy in 2018, and then was hit with this diagnosis of metastasis in 2021, late summer, fall of. And it just threw me into a tailspin. I was frantic. I'd known depression. I'd never really known anxiety, but suddenly full-blown anxiety. All I could think was, I'm dying, I'm dying, I'm dying. I was totally distracted. I couldn't focus on anything in my life. My family took me on a long desired trip to Tofino, which I couldn't fully enjoy because I was just thinking all of the time, I'm dying, I'm dying, I'm dying. Every moment was tinged with the question, is this the last of this? Is this the last time I see this person? Is this the last time I taste this food? Have this experience? It was torturous. And I just happened to see the film Fantastic Fungi. I was looking for a distraction, and lo and behold, there are mushrooms, which not only can treat the cancer in some respects, help treat the cancer, but alleviate this anxiety that I was feeling. And so I just set upon a flurry of activity, trying to find out everything I could about this. And in the course of my research, I decided I didn't want to do this alone. I wanted the benefit of integration with a knowledgeable, experienced person. And I fell upon Theracell, which was offering to connect me with such a person, but only if I could get a Health Canada approval to use psilocybin. So with Theracell's help, I made that application under Section 56 of the Controlled Drugs and Substances Act. and was rejected. I was rejected because my application happened to land in their offices a week after they had brought in their preferred protocol, preferred pathway, which was access through the special access program, which allows physicians to prescribe drugs that are either controlled substances or have not been fully approved, say phase 1 or phase 2 trial drugs. But I had seen that coming down the pipe, and I'd already polled my 3 caregivers. None of them were interested in advocating for me in that way. The beauty of the Section 56 application process was that I didn't need a physician. I just needed a physician's okay that I did not have any contraindications for psilocybin, but the special access program involves physicians in a much more fundamental way, a way that is very time consuming and demands knowledge and so on, and commitment, and incurs their liability. So it's a big deal to ask a physician, have a physician sign on to the SAP process. So none of my 3 care providers were interested. So on that basis, and there were no clinical trials available in Manitoba, which was the other pathway that Health Canada was offering to me. So I went national. Well, I appealed Health Canada's refusal, but I also sought national exposure. So I got a host of interviews, including an interview by CBC that was broadcast nationally. That prompted a response from an underground practitioner here in Winnipeg who contacted the CBC and asked them to pass on her contact information saying she could help me. So I contacted that person. We interviewed each other. She was more than qualified in my mind, but I did say I wanted to give Health Canada a chance to do the right thing, so I wasn't prepared to go full bore right away. But then in a couple of months later, 3 people in my circle passed away. 2 of them, one of them a beloved family member, another one of my best friends. And that just sent me back into that tailspin again. I was waking up every morning with a heavy weight on my chest, and every footstep was leaden. So I called that practitioner and I said, I can't wait anymore, let's go. So I had a middle dose experience in June of that year, followed by a full dose in August. The 2 trips together just totally eliminated any fear of death and had a host of other benefits as well. They just launched an exploration of me and my relationship to my world and the people around me, and most importantly, my relationship to myself. I am a different person. My friends and family recognize that. Some of them say, I'd like some of what she got. And it's just been a marvelous experience. I've had 2 large dose trips since then. They are not to deal with my fear of death, which has been pretty enduring, the loss of the fear of death. What the other trips are for, more to continue that exploration. And because although the psilocybin helped me address a lot of issues in my life, I've still got work to do. Come a long way, but the job is never done.
Oh, thank you, Janice. That is a beautiful story, and it leads to so many segues for our conversation. A few of which I'll park for a moment, and we'll move into, maybe if it's okay with the rest of the group right now, as we look at the various bits we're going to deal with. Let's think about, some of that psychosocial support where your anxiety and fear becomes increased when you have a diagnosis, our spiritual and existential crisis piece, what our life or morality is. As we look at those practical coping strategies that Janice had to deal with as she was going through that, and her relationships and the support networks, those pieces. And then we couple that against the clinical piece. And I think that's where I'd like to explore with our group as well, a little bit more about that and how psychedelics can help a conversation about which medicines might be most effective. Of course, Janice has used psilocybin, but we also know that ketamine can be very helpful. Are there other medicines that we might, want to consider, look at, and maybe explore tonight? What about low-5? Is that something that might be helpful? Because it is a much shorter metabolistic time frame. MDMA has, one of those options as well. And again, I would like this to be a conversation. So I'm going to just put a couple of points out there, and I'd like whoever wants to jump in, or if you need me to, I'm going to tap our panelists on the shoulder. Let's look at, if we want to right now, how about we talk about a little bit about the doctor approach and the healer approach, and how those two might be merging together better in our current situation where we do have an underground that is trying to come above ground. And I'm not sure who'd like to take that first. I'll let you just lean in, Olga or Human, maybe Shannon, who would like to take that first?
Sure, I can speak. Thank you. Yeah, I think, when you generalize sort of the medical system, there are a lot of issues, and I think one of the reasons palliative care evolved as a specialty, sort of stemming from hospice care, as was done primarily in Europe. The idea was really to be holistic, biopsychosocial, and to some degree spiritual. To some degree, like we've lost some of our sort of religiosity and spirituality in society, and there's this gap. And it's very hard to find in the healthcare system that sort of missing piece. I think there are good attempts in palliative care to try to provide that, but one of the big issues is lack of resources. I feel like palliative care, the stigma associated with it, in a way similar to psychedelics, and the stigma is a little bit sort of just like the topic of death avoided. And so it's often this last minute situation where we're trying to like save this like crashing plane a lot of times. And so I think the medical system can do a much better job if we have adequate resources, if we give strength to those of us doing good work. But that's like more broadly speaking. I think with psychedelics, it's definitely tricky. Dealing with controlled substances is tricky, and that's why the underground has had to play a role in sort of keeping that spirit alive. And I always say that there are good and bad players in a sense in both systems, the medical system and underground. You have good practitioners and bad practitioners. So harm can take place in either system. I think the best is for more synchronization between the two, knowledge sharing. But just to point on what you mentioned about the medical options, legally speaking, as we saw from Janice's sort of struggles, it's very hard to get access to psilocybin, which is probably the best researched compound in this sort of domain. And ketamine is definitely a good option. I know Shannon has experience with it. I use it more and more. We just passed a protocol at our hospital for it, specifically for palliative care. It has a lot of advantages, actually, in terms of its versatility, effect on pain, strong biomedical agent. All these tools are strong tools that need to be used with delicacy because they're powerful tools. And ultimately, to go back to what Janice said before we got on, is that it should be patient-centered, and we have to recognize our limitations in the medical system and try to help patients find what they seek. And if we can't offer it, then we have to try to help them find whatever they need. Thanks.
Shannon, Olga, would you like to weigh in?
Yeah, maybe I'll just reflect a few points that are resonating with me. And for Janice, just really hearing as well just like the uncertainty that comes with like preparing to step across a threshold and likely, the choices and the feeling of being able to make choices on what that looks like and just like honoring the struggle about how hard that can be in a system that requires a lot of in a way knowledge about how to move in the system, and just want to lift up Therasil for like the support that they provide to people to help navigate that. I imagine it would be too overwhelming for many to be able to do what you did. And I think you did that on behalf of many. So thank you. Uh, and I think it also gets me thinking about this sense of agency that people have, like stepping into liminal spaces, and this one being one of the biggest. Like stepping into, the next realm, and how we honor that space with and you were speaking a bit about religion, and it reminds me a lot of ritual and ceremony, which is actually it's not really about religion. It's a human resilience factor. And we've seen a lot of societies where like the more ritual and ceremony there are, the less chaos there is in society. And we are really missing that. It's like a missing piece in this modern world. I think we've lost a lot of appreciation for the role of ritual and ceremony as really grounding kind of pieces of order in what can otherwise feel quite chaotic. So how do we support that in ways in a medical system that actually has a lot of ritual and ceremony, but might not align with the kind of ritual and ceremony that people might want in their dying days? So how do we honor those kind of like that set and setting bit around supporting so that people have choice, and it's not necessarily us fitting them into our box. I know we need to do that. There's a good reason why we have standards and protecting people and creating some predictability. And where can we get flexible so that people are in more choice in terms of how it rolls out and where it rolls out. Yeah, so I think I'll just kind of leave it there. That's what was rising to my surface. Yeah.
Wow, that's really powerful. Olga, please share.
I'm going to try and kind of put all of this into kind of a basket. So I'm going to go back to what you were asking the question about, which was the doctor healer paradigm. And I would say, just like the decrease of religiosity or affiliation to a particular faith, the rise of secularism, the rise of modernity, the rise of the biomedical kind of perspective has really overtaken um, a lot of what we do as nurses. I have seen this through my own career. I became a technician. I became the person who did things to people, not with people. And I see within the psychedelic realm, in the nurses that I've had conversations with the doulas, that there is a leaning into and a reclaiming of some of the foundational principles of nursing, which come from, not only theorists such as Gene Watson, who talked a lot and included existential and altered states of consciousness and presence and part of the unknown and uncertainty to be part of what and how nurses care, all the way back to actually Florence Nightingale in relationship to the environment being crucial, not only 20%, but being the most crucial element. And she was really referring to keeping things clean and not eating where you poop. And that was the beginning of, and I think that for our world where we are contaminated in our mind, in our heart, and in our body, and I would even say in our creative spaces, whether that be the womb space or the seed space for the men, I think that there's a real kind of a collective existential desire to understand not only ourselves, but our place in the world. And I think that that is, again, the part of the reclaiming, the part of what's happening, not just in the psychedelic space, but in the global space. The way that we are leaning into understanding indigenous ways of knowing, which not only say, acknowledge the land, but know that you are part of the land. I heard a really wonderful analogy today from an indigenous scholar who said, you know, the water that you drink from the place where you are make you part of the land, because biomedically our cells renew every 3 months, every so on, every 7 days. And so we are born anew, created anew out of the environment in which we live. And that's the kind of connection that the indigenous people are really talking about. We are made of the stuff that we are actually part of and where we live. And so we want to also make sure that we're not contaminating the waters and all of the places, because we are made of the stuff. And I think that the psychedelic space, although goes into the kind of the universal mind and the oneness and the belonging, also speaks about this planet and the materialistic and the physical that we are part of as well, so that we can have a broader understanding. And I think that that's part of the healing. I think that in my own work as sitting and being with people who are at the end of life, it is an extreme privilege, because I am forever changed by their experience. And so there's this cyclical movement. And that's what for me needs to change in the approach of how we are together in a healing modality. Again, I think doctors and nurses have become technicians, and that we are attempting to unlearn and then relearn a different way of being together, a different way of promoting and fostering healing in ourselves and others.
That is brilliant. And of course, being a fellow death doula who is in a quite frankly non-regulated area, and who was called to this later in life, so my professional career aside, when you think about that spirituality piece, about how the integration piece occurs, that's where my sweet spot is. And as I think about how sometimes, and maybe you'd like to speak to this as well, I think about how sometimes being someone who supports someone else's journey, and whether that is with the use of medicines or not, it doesn't matter. It is something that I have found a very interesting, a little bit of a, well, you're not a medical person, so how can you possibly be supportive? And I find it really fascinating. It's only because I have a brain that I'm able to navigate through the language that sometimes is used in the medical system. And often somebody will say, well, are you a nurse? I'm like, nope, I am nowhere near a nurse. Thank you very much. But when you think about those pieces and how they come together, I think all of your points are well made. I'd like to move just a little bit towards, if we could, and you spoke about it a little bit. The journey is part of it. The setting is part of it. But as we go through this process, as we look at psychedelics within a palliative care environment, I don't think we can separate out life trauma from that. And I'd like to maybe have a conversation, and maybe Janice, you'd like to speak with that. You've had a little bit of extra journeying now, and maybe have a little bit more about, oh, there's some other things I'd like to peel back the onion layers on as I'm going through this part of my life. How does that feel for the group in terms of clinical palliative care when you're trying to reduce existential fear, and yet there's still things that we carry that could be powerful, that could be really hard to cope with? And we know that psychedelics can bring those to the surface. So I'd like the group to comment on that as well, please.
Just in my own experience, the trauma thing was dealt with in that first megadose experience. It was unbelievable how I suddenly saw all of my childhood trauma chronologically, and I understood it in a fundamental way that I hadn't before. So that one trip dealt with the trauma. I would say what my issues are now are living, are how to live, how to live these, how to live this time that I have left.
And that is a very profound thing. Shannon, Humen, Olga, do you have anything to add to that at this moment?
We're giving each other nods in the corner here. It feels like a really big topic that we could probably go pretty deep in. It's whatever phase of life you're in, we are grappling with what's informing our lives. And I kind of look at psychedelic therapy in general as a bit of peacemaking with a lot of younger versions of ourselves that have been through, pain and hurt, maybe done to us, and have also perpetuated pain and hurt in the world, and making sense of all of that. I think is a lot, no matter what stage of life you're at. And I think it's a really tall order for somebody that's lived a very long life and has a lot of past selves to reconcile with. So I think just that maybe acknowledgement for us as healthcare providers that are supporting these, and I don't mean just doctors and nurses, but like doulas, allied health professionals, spiritual healthcare providers, like the many lenses that enrich this space in ways that those trained specifically in clinical realms, I don't think do a lot of justice to, based on our training. But just also recognizing that, like, what we bring into those rooms as well, and a lot of us haven't done our own reconciliation work when it comes to trauma, and knowing how to support folks that are like really moving through that pretty difficult process of reconciling, acceptance, and offering, really unconditional positive regard, as Carl Rogers would say. I think we have to actually be able to offer that to ourselves before we can sit in those spaces well. And I'm not sure, as somebody who trains in this space, it's one of the topics we talk a lot about with, is that peacemaking. Have we done that, our inner work, working with our trauma, and to even be able to be somewhat helpful with people that are stepping into end of life, with a lot of that reconciliation work, I think is a big part of it. So I don't know if I'm getting to this. I'm kind of talking in circles. So Human, maybe you can rescue me here.
No, I think that was great. I think it's really important. The, competence piece, the competence provider needs to have experience, and that's one of the hard things to teach in a typical course. And that's why we advocate for experiential learning. The piece that was actually left out of my bio is that I work closely with Therasil, and I'm a trainer for them, and sort of launched the training program here in Quebec. And that's how I met Janice initially when we went to Ottawa to advocate. But I think, the trauma piece is very important. It really depends on how much that individual has done work as well. How much time do they have left to do the work? Like one of the first patient we treated under the special access in Quebec, he had this profound experience on psilocybin, and he was like, I wish I had experienced this sooner, so I had the time to do the work. And that's what we try to tell people, is that the journey will only show you what work needs to be done. And if someone is lucky, in a sense like Janice, they can go through this trauma and do this internal healing rapidly, but many won't. And many will need a lot of work, a lot of hand-holding, a lot of sort of that mindful, non-judgmental awareness. And then hopefully they can get to a place where they can have, let's say, a mystical experience that transcends the ego. And often if they haven't done the work, even if they have that experience, they may end up having to sit with all that unfinished business. So yeah, just adding some pieces here. But great question. Thanks.
Yeah. So two of those pieces are coming together for me that I maybe like to peel out separately. One is the ethical piece as a healer in this space, because I know many of the people listening today are, and move into actually, for me, I have ensuring that when you are a sitter or when you are a co-sitter, that you have done your own work. That's a very important piece to me as part of this puzzle. So that's one of the aspects we could explore. The other one might be, and as we're looking at the different options, whether it's psilocybin and your trauma, it's, we got a question from the floor about 5-MeO DMT and, the low dose protocol and those types of things. So, are there other things that we should be looking at as practitioners as we are going through this process? Is that something that we should be continuing to study, to have responsibility for as people who are in the medical space, and being able to bring this information back to those, I guess those of us, I will say us, because, that are in the underground. So would you like to speak to that maybe a little bit?
I can make a comment there actually, because someone mentioned MDMA earlier too.
Hmm.
And, I think in an ideal world, we have, all the choices in front of us and we can be patient-centered. And Switzerland is a bit like that. So Switzerland was the first country in the world that allowed this compassionate access program. When a physician gets that access, they can then choose to give ketamine, MDMA, LSD, psilocybin. And so that's the kind of model they have. I think we're far from that still. Although in British Columbia, there is certain liberty and people can definitely do things a bit differently. But I think, yeah, for example, MDMA has a very excellent profile for dealing with trauma, for example. And there's only like one major study for this patient population, but I do see a world in which, we will be able to use MDMA if the patient can handle it from a cardiovascular standpoint, because it's a little bit more intense there. I think 5-MeO-DMT is an amazing medicine. The Beckley announcement's really exciting. This particular announcement is for treatment-resistant depression. So by the time it goes to phase 3 and then eventually gets, to our practice here, it's probably going to be years. And then there's if evers based on our experience with MDMA.
Right.
But that's why the underground exists. I personally do not do underground work because I'm trying to advocate and push for in the system, but we face limitations.
Right. And that's, of course, totally appropriate. Olga, do you have anything to add at this point?
Yeah, I'm gonna zoom out again because that's what a perspective taken, a critical perspective taken, and I'm gonna go back to this notion of that you talked about. How can we become aware of our own trauma so that we can do the work, so that we can be as much as possible in the space of compassion. Um, but I want to highlight that a lot of the conversation is really around individuality. And I want us to just maybe be aware of the fact that a lot of the medicalization and part of the breaking down is because it is only focusing on the individual. And so it is your trauma. It's your designation to work on it. And we understand, from whether it be academia, lived experiences, folks within non-privileged spaces will tell you that the trauma, and I will tell you the trauma is far more than a individual, it's my fault space. It's a social, sociocultural paradigm. And I think even in our conversation of whether or not, who's privileged or who can we allow, fundamentally speaks to a pyramid where the top of the food chain is the good doctor who gives you permission or not. And that in itself is actually problematic in the space of, consciousness awareness. It needs to be either turned upside down or dismantled altogether so we can understand that in the ways of traditional knowledge of entheogens and psilocybin and mushrooms being part of that, the healer took the substance themselves sometimes, not even the person who was asking for the healing, because they were the ones accessing, and they had already worked on all of this stuff, so they could handle being in the space to come back and say, this is what you got to do. And so if nothing, we need to have the doctor, the nurse healer accessing that space as well, because it is also going to give us the opportunity to heal the trauma, not only for our individual, lineage of family, but move beyond into the ancestral, into the, one human species, one human organism with all of the diversity that we are. And so I'm always bumping up, against the system to say, if we continue to have this conversation, we're trying to put the circle into the square, and it won't fit. But consider that the square could go into the circle. So I'm always thinking about, the bigger picture, because I, in that space, have felt the sorrow of not only myself, but the deep grief and the deep loss of our humanity. And that's what I would like to reclaim. I would like to, find the healing space, not just for myself, but for all of us.
You're hitting a lot of buttons for me. For me, psychedelics are a great leveler, and I feel like they bring us the therapy. During my megadose experience, I had invited a palliative oncologist to attend. He was somebody I was hoping to recruit into the movement, and so there was my therapist and this medical doctor and me. But I felt like I was initiating the doctor. I was playing an informational, educational role vis-a-vis the doctor through my own experience. And I had gone to the bathroom after I'd come to, and they were chatting together in another room. And at one point they dropped their voices, and I yelled out from behind the closed door, "Hey, what are you saying about me that you think I can't hear?" And it was just such a stark example for me of that pyramid paradigm that we impose on healer-patient sort of thing. I feel so strongly that the patient is their own healer. The sitter, whatever their education credentials, they are a facilitator. And also I would say that facilitator, as far as the sitter's own trauma, don't feel you have to be perfect. I think just be aware of what triggers you, and know that there are things that may arise that because of your own trauma, maybe you're not best suited to help that person integrate. So then just be aware of your own failings, your own inadequacies. Don't think that you're there to heal. I feel so strongly nurses are so well indicated for this work because of their experience holding space. But
Thanks for that. If I can quote Duncan Grady, who's an Indigenous scholar in British Columbia, and he says that, the physician or the healer, whatever role we have, we're like the blade, and the healer is actually like something greater than us. We call it God, nature, the universe. And so we're essentially like a vessel. And so it's our job to stay clean, because if we're a dirty blade, then we're going to go and infect others. And so that's the work we have to do, and we're a conduit for that healing. We're not the source of it. So thanks, Janice.
I want to hop on this train too. Olga, I feel like you opened something here. I appreciate Janice following up on that. There's also this, and I feel like it's a bit of maybe moral distress if somebody that's been in this space for a while. I still consider myself a novice, and probably will the rest of my life. There's a lot to learn, a lot of blind spots. And I worry a bit about our culture that many of us have been conditioned into. Not all of us, but a lot of us. with this idea of, Olga, you were, talking a bit about the, in traditional ways, you may have a space hold actually taking the medicine, and there's, doing a bit of that like spiritual connection so that something larger than them can come through and do that kind of work. And working with Indigenous knowledge keepers and traditional healers from the South, something that's really landed on me is this idea of relational accountability, where in highly functional communities that are quite connected and in a relational space, they're held accountable from an inside out approach, right? So there's a lot of safety when that kind of more direct therapy, people channeling ancestors and whatnot. There's some accountability there in their culture just based on that tight-knit relational network. We don't have that in individualist cultures. And it creates a lot of dangers around people operating in isolation and grandiose ideas and, egos growing out of blind spots that we don't have other relations mirroring for us. So I think I just want to put that vulnerability on the table, and particularly with folks that are in this like final leg of their lived experience here, at least walking on the planet, like changing forms, and our own vulnerability as a culture to be responsible, and myself included, like just an awareness of the inherent blind spots that we have grown up with and have in many ways been embedded in us, and how do we move responsibly with these very powerful medicines when we don't see the whole picture and we don't feel the whole picture because we're not securely attached to our planet or to spiritual natures, nor really to each other. And I'm totally speaking in generalities. I know I can't paint that brush, but looking at our mental health statistics and even some of the challenges in this space, I worry about it. And do we just give people a bunch of medicines that help take that armor off that maybe they have on for very good reasons in the world that they're living in? And at end of life, I'm not sure it's that different in terms of, working with that kind of vulnerability. And how do we, as practitioners, hold that with humility and a bit of beginner's mind in terms of how we go forward, kind of knowing what we know and knowing that maybe there's a whole heck of a lot more we don't know, which might be more than we know. Probably.
Human, do you have anything to add to that? Because that is a beautiful statement, Shannon. Thank you.
No, I think she hit the nail on the head. I mean, our approach needs to be in that spirit. I think we have these amazing contemplative practices and indigenous cultures that have a lot to show us. And it requires humility as a whole, as a system, as a scientific community, as a medical community to be open and learn. And it's that attitude that will enable change. Otherwise, we've become a little bit too sort of stuck in our head. And it's less about the relation. It's more about numbers and
Right.
the bureaucracy, unfortunately.
Right. So I'd like to morph this conversation just a little bit right now. And as we've talked a little bit about trauma and the humility of healers, or, healing guides might be a better way to phrase that, because you're right, the only person that heals is yourself when you're doing your own work, right? Which I think everybody on the panel agrees that's how this is. But what I think I'd like to explore with the panel, because you have more clinical experience and understanding than I do, and Janice, you as well. What do you think would be the hard no? Because Janice was told no, and maybe that shouldn't have happened for her within, the Section 56 and the requirements and the rules. But would there be someone that you think would be either too traumatized, or that you just might not want to encourage those of us in our community, perhaps in the underground, to think about, how would you say, is there a hard no? And I'd like just to throw that out there and hear what our panel has to say about that.
For me, it's people that who have too much fear about the psychedelic itself. A little bit of fear is fine, but too much fear, I think, I don't know, I'm guessing, could be conducive to a bad trip.
You're thinking, Shannon, please.
Well, I'm gonna hop on your coattails there, Janice, and it's reminding me of that relational aspect, and how trust flows through that, and sometimes when people aren't in relationship with the medicine, particularly that first time, that the relationship with the medicine that the space holders have is really important, because that it's almost like borrowed trust, so just like speaking to that, practitioners being in relation, and you mentioned the experiential training feels really important for that, having that relationship when participants often don't when it's their first time. Along that same lines, there are some like biological reasons we don't give medicine to people that might make the risks higher than the potential benefits. Beyond those, I really look at even the wider community of that they practice in, community of practice. It isn't just about the person and the facilitators in the room. It's also about kind of what I spoke to earlier around, if we start, that armor that a lot of us wear moving around this society that we live in, if we start thinning that out, and the integration isn't just about what happens in integration sessions. Like integration actually happens more realistically in day-to-day life and relationships. So like, what is their world, their social determinants of health, that word that we are not great at addressing in the medical system, myself included. Can their environment, relationship, and even like getting their human requirements met, and really making sure their floor is solid enough to hold their more vulnerable selves on the other end of it. And that, I think, is something really important to flesh out. Like, do they have the relationships that they can do that integration work with, that they can be received in that environment of unconditional positive regard? We often, when we're making changes and trying to make sense of things, sometimes we act a bit like toddlers. We don't always say the thing the way it maybe could be said. It's not always wrapped kindly, while we're working through our challenges. And do they have an environment that can hold all of that, like the stumbling, as well as the inspired moments? So I'll go there. And Human, I imagine you would be, I don't want to take the biology piece, because I think you're probably a good one to speak to that one.
Thanks. No, I mean, you said so many amazing things that I rarely hear, so I'm really grateful. I think what you're saying to some extent also is that, these medicines, they don't have an inherent direction. They sort of loosen frames, they lower defenses, and you don't necessarily automatically move in the right direction. And, right is something that's arbitrary, but you can get worse. And many people have gotten worse. And the setting, container, all these things influence that. And for sure, that holistic approach to our assessment when we're deciding if someone is a good candidate matters, and all these factors matter. The relationships really matter. So I think that's a key piece. I think biologically, I mean, someone that's very close to the end of life, they have to be aware that they may die in that session. And I like to bring up this story as often as I can, but historically, the first patient who got a Section 56 approved in Quebec, and that's how I got connected to Therasil, was this amazing woman who really wanted this experience. And long story short, her treating oncology team was really against this. And this was very early on. And we were sort of afraid to treat her against the oncologist's will, because we didn't want a college complaint and this whole situation getting out of hand. And by the time she was told that there's nothing else to offer her, we sort of reevaluated her for the treatment, and she was at the end of life, and we had to be very honest that, listen, you may actually die during this experience. And she clearly, even though she really wanted this for such a long time, said no. So that's something to keep in mind. And luckily, we have this new study out of Boston, even though it's only, I think, 11 people treated, where they did do this in a hospice setting, and it was shown to be safe. And hopefully, we'll have more evidence of sort of more Timothy Leary style, psychedelic administration closer to death. The other piece I would like to say is that, there's a psychological vulnerability that still applies. The reality is these substances sort of push us towards that anarchy as one way of looking at it. And so if we are prone to, let's say, psychosis and mania and things like that, it is still a legitimate possibility. So just taking that into account with the overall picture should be part of the assessment.
Olga?
Yeah, I'm wondering if so a hard no, and I again wonder if I think we need to maybe ask who's being asked for the approval or the legitimacy. So I think that there could be different points at which we could have those conversations. And so I'm just putting it out there, are we opening things up where we have the level of self-autonomy and freedom so we can access altered states of consciousness and there isn't a limitation to our personal desire for that, not necessarily for a therapeutic process, but for an exploratory process. And then, to the level of safety, right? Like we oftentimes in healthcare and in nursing and in a caring profession always talk about keeping people safe. But sometimes we keep people safe so that we feel safe because they might be entering a place that isn't safe and it dysregulates us. So we need to be aware of that there is sometimes a caring where I'm going to care so much that you're not going to be able to really do anything that you want to do. So we're just putting it out there, right? So I would, I work sometimes with folks with cannabis because I think cannabis is a mild psychedelic. It's one of the plants that has been kind of thrown out of the psychedelic garden, but I think it can be really, really helpful to initiate and introduce people to kind of this liminal space or the altered states of consciousness, if you will, that has a level of groundedness and control and still can include vastness and spiritual connection and heart connection. And so in the cannabis world, we always talk about going low and going slow. So maybe we need to reframe the treatment, and instead of the big bang, and instead of the big trip that sort of creates the ontological shift, which can dysregulate so much into a psychosis, then maybe we can look at the microdosing and the way that we can slowly help someone to acquire insights and then be able to integrate that. And maybe at the same time, we're creating the social structures that allow people to come back to the places so they can continue to be safe. Let's bring back the studies from long ago where the prisoners were given LSD, I believe it was, or maybe it was psilocybin, and they did have a change of sort of perspective and understanding of their predicament. But as soon as they entered sort of civil society where they didn't have the safety of the group and the way in which they could be in this new way, disarmored, as Shannon, alluded to, then it fell apart. So it can't be one or the other. It's got to be, the quantum of psychedelics, the self and the social and the spiritual, the cosmo kind of perspective, so that we can move in a way that really, works for all of us. The we, not just the I and them. I think that, I'm just, I feel like sometimes, those folks who aren't here in physical form, like Ram Dass, I continue to listen to a lot of his, works and reclaiming again, we, in the books, we only capture a small amount, and there's so much knowledge there that we can dig up and we can utilize. Nothing is lost. And just because it was in the past doesn't mean that it can't necessarily work. I'm at the age where I'm starting to recycle again, right? So every 30 years, the ideas are recycled. So there is never anything new because nothing's ever destroyed. So how can it be?
I'm just really curious about this. I just feel like the person that's facing death, they're already in a different place. And safety has a different meaning.
Absolutely. It is an
I think,
altered state of consciousness. Absolutely.
yeah, and the word safety is triggering for me because at one point the chief medical advisor for Health Canada was on a Zoom
And
call.
so
Yeah,
consider
telling
that.
me that they were denying me for my safety, and I'm just going, I'm dying. What are you saving me from? Like, it was just, I mean, it is the height of absurdity for me.
Yeah. Mm. Mm.
I will grant you that I will grant you, you guys are all more knowledgeable. You've had more experience with patients than me. I will grant you that there needs to be some concern for the patient's safety. But from the perspective of a dying person, we're already in a different place. I think we can. There's not much that's going to make us more scared.
Janice, that is so true. And bless you for saying so. You know, the people that I've worked with, often it is one of the things that we spend the most amount of time on when we're walking and talking is the fear of what's happening. And, you know, the existential questions of, you know, I don't believe in God, Kim. Okay, I can work with that. And then we kept having to have conversations about why. Well, you know, it is part of our humanness. It's part of our connection to one another. It's part of that piece. And thank you for bringing home the fact that our need for your safety is kind of crazy, particularly in a place and a space where we also offer made. So we allow you to have control over the end period, but we don't allow you to have control over a journey that may or may not hasten the end, but might actually give you some comfort as you're moving through. So would you like to speak about that? Shannon, maybe?
Well, I just want to hold a moment of Janice, you said something that kind of struck me in a good way around, you know, you all have more experience working with patients, and you know, it's in the reality, you have the most experience of any of us on this panel in terms of where you're at and where a lot of people at. We're not there at the end of our life. We're like conceptualizing it. And yeah, I just want to like honor your voice in this, and like truly you're the expert. With that blowing in mind is just for us practitioners that are doing these safety assessments, it's causing me to like really turn the mirror around and who am I doing the safety assessment for? So many times in my nursing training, and I think it's very similar for physicians, is we're worried about having becoming a target of somebody that wasn't competent in their practice. I just wonder about us asking that question around who are we keeping safe? And when we're talking about patient-centered models, I think it's a really important question to ask because so many of us have that conditioned into us where maybe we're looking at the wrong person in terms of safety. So thank you.
And I'd just like to comment on a question that was asked about the role of psychedelic-assisted therapy play in relation to medical assistance in dying, and are people who apply for MAID being informed of psychedelic-assisted therapy as an option? So, Human, are you familiar with that? Is that a thing at this moment?
Yeah, thanks. Just to sort of finish that thread on the previous sort of topic, I think, you know, the reality is I'm in full agreement with Janice, and I think we should be able to control our consciousness as long as we're not harming others
Hmm.
primarily, and then harming ourselves is maybe arguable. But the liability in that process of the Section 56 going to the special access was shifted to the physician. So this prescriber is now medical legally liable, and we are living in a system where there is real liability. A lot of it is because of the bad things that physicians probably did in the past, and now we're paying the price for it. But yeah, I think, the argument that we've been able to use really in this movement to get access has been because of MAID. The idea is, okay, well, you're going to pay for someone to die in the system. Why can't they choose this? The system requires evidence. And so luckily there's more and more evidence coming. There is definitely no systematic way, and there should be. A lot of people are arguing for this, that you should systematically be notified of options when you're applying for MAID, or maybe you should systematically get qualified, if you're at the level where you qualify for MAID. And there are a lot of good efforts. I'll point out to the P3A group in Quebec that I'm fortunate to be a part of. It's p3a.ca. But Professor Michel Dorval and the team, they've developed a bunch of good tools. One of them is a psilocybin decision aid for palliative care. So it just got published, and it's this brochure that can be printed really nice as an example of something you can have as an offering if someone's applying for MAID. It has to happen at an institutional level at this stage, or just in our private practices. But the goal is, yes, let's have a system-wide change to recognize options and give people the choices. And the other question that a lot of people ask is, would it change someone's mind about MAID, having a psilocybin experience? And my experience is that it's mixed. Sometimes, people have this sort of ego dissolution, loss of fear of death, and are even ready to die sooner with MAID. Because MAID ultimately gives you this power to choose how you want to die, where you want to die. And then in some cases, it may give resilience, and someone, will opt to do it later, or change their mind. But yeah, I'll put this website in the chat. Thank you.
Thank you. So that's interesting that you mentioned that, and maybe we could explore together a little bit. There's a program that is out of Winnipeg, actually, Janice. A gentleman at the University of Winnipeg developed a program in dignity therapy, and it's essentially a form of legacy conversation. And as part of their study group, they actually asked the question about, after you've done this piece, many of the individuals felt that they actually didn't need to go forward with MAID right away, because they had this other component that gave them meaning and some comfort in the fact that they were giving something back to the world, whether it be personally for their family or bigger picture. So that's an interesting conversation as we go through this piece, about MAID, about the control piece, and about, is that part of the disconnect of our humanness with one another? And I'm just saying that as a comment, perhaps, but if somebody would like to explore that a little bit, I'm also comfortable with that as well.
Well, I just want to throw in a cold-hearted kind of perspective on this. And I know there are actuaries that looked at MAID, and they were calculating savings to the health system of having a program like MAID. And I believe very strongly that psilocybin helps extend life. It was true for Thomas Hartle, it was true for Laurie Brooks, and it is true for me. I'm 2 years past my original prognosis. I think the elimination of the stress has eliminated that contributing factor that could have already could have sent me somewhere already some time ago. So I just want to make that claim on behalf of psychedelic-assisted psychotherapy in end of life. Human might have a perspective on that as well.
That's been my observation as well, to be honest. Like, I definitely see that patients beat their prognosis. I think we need a study to see if this is actually true or not. And I'm happy to have joined this network recently called CanPact, which is based out of Calgary, and it's a specific multi-year project to study cancer patients and give them sort of access to mindfulness-based psilocybin therapy. And I think through initiatives like that, we will hopefully be able to study. But I agree with Janice. I mean, my observation has been that most of my patients that actually did psilocybin have outlived their prognosis.
Which is fantastic. So again, question from the floor. What advice would you give to create a pathway that leads to a hospice that has a focus on ecotherapy with psychedelic-assisted therapy as its focus? And do you believe something like this could be fully legal and possible? They put in the future, but I might want to add in the near future. So I'll leave that for the
I mean, I think that's a great idea, something I've been considering. And honestly, like Montreal is a pioneer in palliative care, and some amazing hospices here that I've been to that really like give you hope on a future healthcare system that is holistic, beautiful hospices where they bring you, you know, animals to your bedside, like a horse can come into your room literally and things like that, which is amazing. And I think, you know, it's very doable. Like with a research protocol now, we can easily do that. And we're trying to incorporate at least ketamine assisted therapy in one of the local hospices in Montreal. And for sure, at a minimum, with the research sort of infrastructure, it's very doable. And, you know, if someone just does it and gets the philanthropic type funding alone, we can easily do that now through a research lens.
Olga, like to share?
I'm going to add a little wrench into our conversation. Part of my work as a end of life nurse educator or an end of life doula is to actually manage some of the expectations that client families may have about the care. And what I'm particularly speaking to is the fact that, number one, most people wait until almost too late to access palliative care or any kind of support. So we still have a very culturally sort of defined understanding of what palliative care is. Those of us inside who have been working on expanding that definition for the past 30 years, we are still doing the work. But I think we also have to understand that, we don't have as many palliative care providers as we need to facilitate, really good care across the country. And so while I'm hopeful that there are initiatives, I also am hopeful that the underground will be able to safely surface so they can sort of be the beacons, because as somebody had reminded me yesterday, we're not in a psychedelic renaissance. The psychedelic movement has never died. It is not resurrected. It was underground, alive and well for the past 30, 60 years, and will continue to do so because it's fundamental to, the social structures of humans. So I think we need to be cognizant of the fact that sometimes our vision doesn't match the application of what we want to do, and that can create a lot of stress. And I've seen that in the MAID process where, it's highlighted that people can access this and yet they can't because of where they might be, because of the shortages of connecting folks. And so just a level of groundedness of, we can blue sky and we can look towards the future, but I want us to also be aware that we need to do more public education to really empower citizens to be able to understand that they are the primary holders of their care, and to give them the tools so they can be able to advocate for themselves. Because right now, even within MAID and psychedelics, you have to have the means in order to fight the fight. And there are many people who may benefit from either MAID or psychedelics or end-of-life care support, and they actually don't have the means to fight for the thing that they have been told that they should be able to access. So I think that it's feasible. I also, a lot of folks don't realize that many hospices are not funded within the healthcare system, and that there's such a huge reliance on the community. And so there needs to be a little bit of that, sobriety of understanding what's actually happening. Because we don't talk about end of life, because we don't plan for it a lot, we may not actually know that we don't have as much support as we thought we do. So part of my work is to really be helping people to educate themselves. You know, even in the doula world, I have trained, I don't know, 1,000 people who wanted to be doulas. And it's not because they wanted to do it as a profession. They really wanted to do it for themselves and to help their families, because there's no end of life public education. Nothing. It's not available. You have to pay in order to access that knowledge, which is the basic human, you know, things that you need. And I would also say that, you know, just like birthing and dying, they're not medical events. They may require some medical support sometimes, but fundamentally they're not. But they have turned into, we have been socialized so much so that in our uncertainty, we are seeking the help from the medical system, which actually may traumatize us in their support and in their help.
Couldn't agree more. Yeah, it's interesting. Certainly we could talk about that more, and I don't want to take over the conversation, but I appreciate your comments, Olga. And certainly, I think those of us in the doula space have absolutely seen that time and again. Even from the perspective of being a doula and going into a hospice or going into a space that is more medical, you know, they'll look at me and go, you know, but that's okay. You know, it is what it is. So I've got a question from the floor. Human, can you please share some of these hospices? It's my path, Olga. I do want to go into this work and help bridge between the two worlds. So that's one question. The second one is, can you address some of the costs involved in some of your different programs and treatments? Here in the States, these are very expensive. So,
I just put two links for two of the hospices I mentioned, and they are, one of them is public-private partnership, and one I think is fully private in the sense that it's philanthropically ran.
perfect.
There are expensive hospices as well that, you know, you can pay for. You know, I just want to say, Olga, what you said is absolutely right. You know, that's what I meant with resources for palliative care. We're lacking basic palliative care. And even these basic therapies, like, you know, I think it's Chachanoff that you mentioned, doing dignity therapy and access to these kinds of things, and even spiritual care. These things are lacking in our system. So palliative care is still, to a large extent, hospice care. And we want it to be palliative care early at the time of serious illness diagnosis. And patients with palliative care alone do better, you know, without psychedelics and all of that, you know. So in terms of the costs, I mean, I'll say that Quebec, we became the first province in Canada and probably the first place in the world where we advocated, and the psilocybin treatments we do as family physicians is paid for by the public system, and that's sort of a breakthrough. But in the majority of places, it costs money, and it's definitely cheaper in the underground. And you know, just the thing that I didn't mention on liability is that the liability for underground practitioners is much less. You know, so someone can go without any qualifications and become an underground practitioner. And if something goes wrong, they don't get sort of penalized in the same way where they like lose professional sort of licensure and stuff. And that's just my understanding of it. But these are just some issues that.
Which I think from our association in the Psychedelic Association of Canada is one of the issues that is of interest to practitioners. Not because I think that there are many practitioners who are ethical and appropriately trained. But there are also those that do, you know, a week and a half and then want to go and help, and in a very loving, kind way, but not necessarily should they be doing that on their own, and finding an appropriate, because it's the underground, finding an appropriate group of mentors to make sure that as you go through and you begin to do this work, that you do it in a good way that is, you know, essentially like all of you doing no harm while you're doing it. So yeah. Shannon, do you have anything to add to that?
I'm just nodding here. Yeah. It's good. I'm not in the hospice space specifically, so leaving it to these folks.
So this has been so far pretty interesting to me. I do have one question that I would like to share, and then maybe we'll get you ready for last thoughts. But what are the biggest drawbacks of using the special access program to access psilocybin for end-of-life care? What does the ideal system of access look like for this population? And boy, there's a loaded question. And anytime in the near future, could it be provided by prescription? Could be provided online, but okay, anyway, let's park that for a sec. Okay, let's hear what you all have to say.
I can jump in on this one. We do work quite a bit with the special access program through Roots to Thrive, and it's over the years we started working with it when it was in the Section 56, and actually it seemed a lot easier than the special access program in terms of timing and communication with Health Canada. It's highly volatile in terms of like how long it takes for approvals. We largely do group therapy, and we used to do end of life group therapy for psilocybin and have entire groups come through by applying for the group and receiving approvals as a group. We have not been able to do that with the SAP program because of all the volatility between individuals and a lot of unfunded work for physicians who are responsible to do that application but are not paid for it out of the system. So it becomes a major equity issue. You have to be in relationship with a physician that is able and willing to donate their time to do that application. And it's not just one application. It is multiple, like it generally gets denied or they need more information and they have to prove that they've done, and right down to, oh, they've only tried this many medications, try more SSRIs, or they haven't done CBT, or, it gets a bit maddening for physicians that are, again, donating their time and participants that are like kind of at their, like they're going through this because they have generally tried everything else. And many people say to us, this is my last hope. And they're stuck in this situation where they have very little agency in their access, and so do the clinicians. So I don't have a lot of I don't have a lot positive to say. I'm grateful that program exists. I think it's important we have some form of access, but it's not for everybody, and it very much is related on your resources and your relationships. I also just want to mention that just because you get approved for SAP does not mean the medication cost is covered. Many of the labs, we've been lucky, like we often get donated medications from these labs, but they're very expensive for folks that are having to buy them privately. So there's one barrier. And finally, the only time that is covered, like related to the costs issue, is short amounts of the physician time. So you might get, depending on if they're a specialist or a general prescriber, like 15 minutes covered, maybe an hour covered of an 8-hour session. So somebody is having to fund the majority of what people are getting otherwise. So again, one more barrier where it's really for people that have resources and connections. It's not an equitable access path. I will leave it there.
Mhm.
And then there's the
Yeah.
dosing thing.
Mhm.
Strict one
Oh,
dosage amount that may or may not be appropriate for the individual involved.
not patient-centered at all. It's, yeah.
Mhm. Human, you have something to add?
Yeah, I mean, everything, I agree with all of it. I think really the summary is this system is not meant to be for psychedelics. The system is meant for, let's say, cancer drugs and HIV drugs back in the day. That's what it's designed for. It's overcapacity. The people that are granting and doing the assessments are not qualified. And so we need a body that is qualified, that has the experts, that has the lived experience, that has all of that. And they need to do it like that. It's ridiculous. And someone says it's demoralizing. Olga, yeah. Patients feel like they don't deserve it, when they get denied, when they get, pushed back, and they're like, is there something wrong with me? It just brings up shame, and it's such a difficult process to deal with. So I prepare people before going in. I'm like, you have to be ready, and it still hurts.
Mm. Wow, we are on our last 5 minutes, and I do try to keep us on time. So I would ask each one of our panel to think about, what would you want to say to this group of interested individuals? Just 1 minute. What would be the one thing you want to say? And I'll put Olga, you on the hot seat first.
Wow. I'm not sure. Can I pass it on and then see what I have to say? Kind of on the spot. Again, I think, and we're talking about folks who are interested in engaging in psychedelics who might be facing their end of life. Is that what you're saying, Kimberly?
Sure. Yeah, I think that would be a really good place for you to lean into. Sure.
Let me think of something kind of philosophical. Maybe sometimes the answers to your life may be in the places that you least expected. I don't know. Maybe
That's
something like
cute.
that. Again, I think sometimes, people have expectations in sort of, seeing God or being united with the Almighty, and sometimes that doesn't happen. And so if you don't meet the Almighty right away, maybe it's not the time yet, or maybe it'll come again. I'm not sure what I would say. I oftentimes will say to clients, the client families, is I have no idea what this experience will be like for you. I've never been there, so I can't say that about psychedelics, but certainly I can say that I don't know what it will be for you. But certainly I will, as a companion, make sure to keep you safe and warm and all that good stuff, and help you along your own journey wherever it may take you. I won't leave you.
Yeah. Thank you. And Human, what would you like to share with the group if you had one final thought to share?
Yeah, my thought is, we have a responsibility to educate ourselves and educate those around us. I think, the psychedelic bubble is a bubble. It's growing. When we're in it, like, oh, there's so many of us, but like if you look at society, there's just so much misinformation and stigma. And if we want systems change, we need all members, like, knowledgeable, including other physicians and other care providers and people in society that, ultimately lead to decisions being made. So educate ourselves, educate those around us. I think that's really important.
Beautiful. Thank you. Shannon, I'm going to kick you up next.
Yeah, I'll just maybe speak from the provider training side of things. There's a lot of people that have had experiences of psychedelics that have been life-changing, and it's not uncommon for people to want to be a therapist immediately after that happens. And I really recommend people do your research. It's getting access to these in the regulated space is not easy. I have no issues with an underground that carries a lot of that load. And it's really important that people do their research and really make sure that the folks that you're partnering up with come with some really strong references, so that you are putting yourself in a safe environment in those vulnerable states. And that includes people that have done their kind of own work and that have a long-term relationship with the medicine. Just like a lot of traditional cultures, you would never pour medicine unless you've been in training for upwards of 20 years. So doing these like weekend retreats and week-long trainings and even year-long trainings, that's a Western thing. So just like really holding that context in mind in terms of how we attribute our expertise, myself included, to folks that are kind of reaching out for help out there.
Thank you, Shannon. That is wonderful. And of course, Janice, I started by asking you, and I'm going to finish by asking you for your
That's a
final thoughts on this beautiful conversation.
very heavy responsibility.
No, it's, I don't want you to feel responsibility.
Well, I will
Like I
not
said.
inject my own personal beliefs about death and the meaning of life and all of that. I will just say, do not be afraid of psychedelics. Be open. Be open to psychedelics. The gifts they have to impart are wondrous and life-changing, life-giving. And yeah, they're ours. They are ours. They're here on Earth, and they have been in continuous use by humans for tens of thousands of years. And I just fundamentally reject that the government can legislate them. They're ours.
Perfect. I would say that is a beautiful note for us to finish. And I would like to thank each of our panelists for your commitment, your time, the fact that you were willing to spend time with us and educate us. And we appreciate each and every one of you. My heartfelt thanks. And I am so grateful to have been able to spend time and space with you. I wish you all well, and thank you to all of the people who joined us this afternoon or this evening. We appreciate you and your input and questions as well. Thank you very much. And to the Psychedelic Association of Canada family, please feel free to, if you haven't already joined the association, we would welcome you to check out our website. It will be in the chat. I'm sure Cheryl, our support person, will put that in, and please do feel free to come join us. Please go and find our panelists wherever and whatever information they've given you, and I wish you well. Thank you very much, everybody. Have an amazing and wonderful evening. Thank you.
Thank you so much.
Thank you.